Well, thank you very much indeed for those kind words, HT. It's always an absolute pleasure to visit Hong Kong and to rekindle and make new friendships here. So thank you for those kind words, and good afternoon, ladies and gentlemen. I've chosen this title, Choosing Wisely in Surgery, an international perspective, because I think that it reflects the meeting over these next couple of days. But before I talk about the topic, I do feel I should say a few words in honour of GB Ong, who is really behind so much of the collaboration that exists between Edinburgh and Hong Kong. GB, as everybody here knows, but maybe our colleagues from Edinburgh are not all fully aware of, was born in Sarawak and came to Hong Kong for his early years of surgical training. And he rapidly became a man who achieved firsts in all milestones in professional life. And he was, in fact, I understand, the first ethnic Chinese to have held a chairmanship in surgery here in Hong Kong. And I believe that the Queen Mary Hospital, when he went there, he had $1,000 a year budget, no operating theatre, and 60 empty surgical beds. So what a huge amount he managed to change over the years. And as we all know, he's described as a giant amongst men. And this topic today, choosing wisely, well, here's the first man who chose wisely all those years ago in the 1960s, when he established this relationship and friendship with GB Ong that led to the first diet of the FRCS examination, the first overseas diet of our college's examinations anywhere in the world, in fact, in 1970. And that relationship went on from strength to strength. The GB Ong medal is just one of the ways that GB Ong's practice lives in our memory. And here's a picture of myself this last year awarding the GB Ong medal in the UK to Miss Nicola Henderson. She's actually one of my trainees, so that was a double pleasure. And she's also some years ago presented here in one of the Conjoint meetings. Of course, there is the GB medal, which is awarded for the best results here in Hong Kong as well. And there are other ways that we remember GB. Here at the Edinburgh College, this is a quincentenary hall, and one of our resource and learning areas in that building is dedicated to the memory of GB. Now, these lectures, the GB Ong lectures, I understand started around the year 2000. And they've been a pivotal part of all of the surgical meetings here. And you can see that I follow some pretty illustrious names. Harold Ellis, Professor Lord Darcy. So I don't feel under any pressure at all today. Well, not much. I've chosen the topic, Choosing Wisely, an international perspective, not only because it reflects this meeting, but I think it also reflects and resonates my own view about how we should deliver clinical and surgical practice, whatever stage of our training or career that we're at. So if I rewind the clock a little bit and talk about how Choosing Wisely began, it was a movement that started around 2012, and it was the American Board of Internal Medicine. It has a charitable arm, a foundation, and they're based in Philadelphia. And their fundamental purpose is to try and advance professionalism by funding various projects. And Choosing Wisely was in fact one of their first and probably one of their most successful projects. And it was born out of the concept that in America there was a growing feeling that perhaps a lot of what we did and what we set out to do was maybe not exactly relevant and in the best interest for the patients. So there were these three underlying premises. One, to try and reduce waste in healthcare. Another, to try and avoid risks associated with unnecessary treatment. And perhaps to achieve this, to ask us all to come up with our top 5 lists of procedures or interventions which seem to be of low value both to the patient and to the practitioner. So it's quite a simple basic premise. And it was picked up pretty quickly in the USA. 70 specialist medical societies, not only surgical societies, medical, laboratory-based societies as well, picked up this concept of choosing wisely and made over 400 recommendations as to how one might select out interventions that are not of particularly good value to a patient. Now, there's nothing absolutely new about this sort of a concept. If we go back to Mesopotamia, 30 centuries ago, the Code of Hammurabi, one of the first men to lay down the laws of the land, reckoned that a surgical practitioner who was overzealous deserved to lose an eye or a hand. Now, we have got a little bit more gentle than that, but it's a long-standing principle, don't be overzealous. And a bit more recently, Ernest Codman, a Boston surgeon, who was very keen on modernizing clinical practice. In fact, he's one of the first surgeons who started systematic follow-up of patients who'd had an operation, so he could see what outcomes were all about. He put this cartoon out, the Bayback Golden Goose Ostrich it was called. Now, this was really to parody his professional colleagues in Boston, who at that time, in the 1910s, 1920s, were offering prophylactic appendicectomy for people who had vague abdominal pains. So no scientific basis behind offering the procedure, just offered in the hope that it might make people better. So he was aware at those days that there was an issue about waste and procedures that could potentially do more harm than good. And then if we look in the UK in the 1930s, this is the incidence of tonsillectomy in school children. And in 30 boroughs within the London area, there was a 20-fold variation in the rates of tonsillectomy, purely governed not by the need for the operation, but just by the views of the school medical doctor who was looking after that particular district. So clearly, once that situation was addressed, you can see the sudden drop-off in the frequency of the procedure. And then if we look a little bit more recently, this is a fascinating read. It comes out of how many more studies will it take, a compendium of evidence which has come from the USA. And you can see that surgery is seen as an area where there are potentially unnecessary interventions, highlighting hysterectomy and carotid endarterectomy, the indications of which for might not be properly absolutely applied. And then, of course, there's the more recent issues, the ever-increasing healthcare spending, eye-watering amounts of money being progressively spent to deliver healthcare, which is clearly going to put a pressure on us eventually, because quite simply, we're not going to be able to deliver the level of healthcare that everybody would wish if these graphs continue. And we can see that the USA is right up there in front, and the UK is struggling somewhere midway and towards the bottom of the league table, which might explain a little bit why our health services are so cash-strapped at the moment. You can translate this another way too, and this is some interesting work from the Commonwealth Fund, which looks at cost-related access barriers for patients. And you can see in the US, 37% of people may feel that they can't get the healthcare that they need because they can't afford it. And even the UK, which is supposed to deliver healthcare free at the point of delivery, still 4% of the population feel that they can't get the healthcare that they require. So, choosing wisely started off strongly in the USA, And really, the baton was picked up by Wendy Levison, who is a physician based out in Toronto, who I was fortunate enough to meet a couple of weeks ago. And she espouses the three values that we've really been talking about already. The need to provide evidence-based lists so that you only do what's evident to be good, and to question some of the things that perhaps might not be so good, and then to avoid this concept of undertaking a procedure which is of low value to the patients themselves. And really it's been a sort of bottom-up project, so that physicians and patients have been energized to deliver this, and the media has been engaged, and the stakeholders, the trusts, the healthcare institutions, are really bottom of the list. So that means that it doesn't appear to be something which is led from the point of view of needing to deliver economy. It's delivered because it's directed to providing the best management for a patient. So it's not solely an economic drive to drive down healthcare expenditure. And they use some quite interesting graphics in the Canadian program. More is not always better. I think I'd want to give that hot dog a wide berth. But seriously, these are the 4 questions that this particular program wishes patients to engage with a doctor. First of all, do I really need this test or treatment? What are the side effects? Is there anything simpler that you can do? And I think terribly importantly, and I think Stephen mentioned this in his opening words this morning, what happens if I do nothing? Very important, especially when we're dealing with patients who've got lots of comorbidity and may be moving towards the end of life. It's also, choosing wisely has also spurred quite a lot of interest into asking physicians why they organise unnecessary tests. And here is a small telephone study of 600 US physicians, and perhaps not surprisingly, top of the list is concerns about malpractice. So in other words, you're providing yourself a professional safety net. But further down, and quite significantly, patients insist on an investigation, and they're not going to be happy unless you've undertaken a certain algorithm of procedures. So there's an element that's physician-led here and driven, and there's also an element which is patient-driven as well. And here are some of the early results, not surprisingly from Toronto, for example. And they've used some quite catchy phrases to try and engage physicians and hospitals. Drop the pre-op, and you can see the results and the number of investigations, emergency department lab tests, for example, ICU chest x-rays, a variety of economies which have been possible to be made. And then also in Toronto, this concept of reducing the need for blood transfusion. Why give 2 when 1 will do? I have a slight problem with that, because I've always been taught as a surgeon that if you only need to give 1 blood unit transfusion, you don't need to give any at all. But maybe there is, a little bit of element there of being sensible in terms of rationalizing blood transfusion. And they say they've had a 15% reduction in blood transfusion usage. And here are just some examples which seem incredibly sensible to me, which have come out from the American College of Surgeons. I do pediatric surgery, or I did. Don't do a CT scan for suspected appendicitis in children. Avoid chest x-rays if they're not essential. No colorectal screening in asymptomatic patients who've got a life expectancy of less than 10 years. Difficult to work out who that particular population is, but it's quite interesting. Caution in use of CT, and the issue of sentinel node biopsy before axillary staging in stage 1 and stage 2 breast cancer. I can't particularly speak to that, but that is one of the recommendations based on this Choosing Wisely campaign that has been espoused by the American College. So clearly, the process is being engaged in America and in Canada. And Wendy Levison, who's the driving force behind this, has taken this concept beyond North America and introduced it elsewhere. And if we just look at the first couple of bullet points there, her aim has been to create a strategy for developing the Choosing Wisely campaign across the whole of the globe. And we've had 3 conferences so far in Amsterdam, London and Rome, and you can see there's progressive recruitment of interest across the various countries, so that now Choosing Wisely is active in parts of Asia, South America, Europe, as well as North America. And these are the campaigns that have been launched to date. The UK, you'll see, is right at the bottom of this list, and we have in fact not yet launched our campaign. It's just about to go live in the next couple of months. So I should say a few things about the UK, before I take things any further. If I was to talk about the NHS in the UK 5 years ago, this is probably the slide that I would put up. There's a storm brewing, and here's our bed, the NHS, floating inexorably towards it. If I was to look at it now, we've moved one stage further, and we've got the perfect storm. Growing population, aging population, chronic ill health, appalling lifestyle, and financial recession. Doesn't get much worse than that. And just to sort of fill that in a little bit more detail, we're expecting a 10% rise in our population over the next 30 years, taking into account the current inward immigration of about 180,000 people per annum. We've got a bulge in the elderly. There will be a 10% increase in the next decade of patients who are over 65 years of age. And all this is set around this eye-watering shortfall in funding, 2 to 9 billion for health and similar numbers for social care delivery. So there's lots of reasons why we're going to have to choose wisely in the foreseeable future. And matters are made a little bit more complicated because the United Kingdom is probably only loosely united at the moment. We've got 4 devolved nations and we've got 4 devolved health services, all of which are slightly different in their approach to healthcare delivery. Probably the most problematic being the one that's in England. I'm quite glad I'm living in Scotland at the moment. And not surprisingly, because we've got different health services, here's some data that shows just how long it takes to wait for a hip replacement. And you can see that you have to wait twice as long in Wales as you do effectively in England and Scotland. So there is some variation in performance there. And it's perhaps not surprisingly, because of these differences, the 4 nations have decided to try and take Choosing Wisely forward in slightly different ways. Wales, first out of the trap, my home country as it were, and perhaps the one most financially impoverished from a health delivery point of view, has come up with the concept of prudent practice. Choosing Wisely, prudent practice. And these are the basic tenets of their programme. First, do no harm, minimum appropriate investigation, only do what you can do, which essentially means if a nurse can see a patient, there's no need for a surgeon to see a patient. Follow-up, for example, or maybe routine preoperative checking. Promoting equity, I'm sure we would all sign up for that. And then this rather clumsy term, co-production, which implies a better relationship between patient and physician. And then in Scotland, our CMO has produced her annual report based around realistic medicine. And there are 6 tenets that form the concept of realistic medicine. It's all the Choosing Wisely theme. And if I say just a few things perhaps around shared decision making and reduction of harm, I'll leave the others on one side. I like this quote. I'm not a great man for quotations, but I think this is very true, and it's really the core of this business of choosing wisely. A single biggest problem in communication is the illusion that it has taken place. And matters in Scotland have been brought to a head by this ruling, the Montgomery ruling, where this lady, Nadine Montgomery, gave birth to this boy 19 years ago, a long labour because of shoulder dystocia, and the child was born with brain damage. She believed, quite rightly, that if she'd been given the choice and explained the risks, she would have opted for a caesarean section. It took her 19 years to get this through to the Supreme Court before she got this ruling in her favour, which has changed the landscape now in the UK, because now all patients have to be told and warned of the material risks that any procedure will lead them to. Patients are also more interested. They can go on a website in NHS England if they need a colorectal cancer operation, put the name of the surgeon in, find out what his 90-day mortality rate is and how often he does the procedure. Isn't that one way of keeping you on your toes? But there is another problem too. We do tend to be very much driven, formulaic, going down a treatment algorithm. And these are the SIGN guidelines that we have in Scotland and the NICE guidelines that we have in England. But on their own, they don't help us that much, because our patients, they don't just have a single problem. They've usually got multiple problems, and these other problems need to be taken into account. I've been struck by this publication from Taiwan, which looks at the effect of comorbidity on outcome. And you can see going from red to purple, there's increasing comorbidity, and just look at the effect that has on mortality for especially major resections, as compared, for example, to a lesser risk procedure such as breast. How do we counter for this? How do we take this on board? There's no algorithm that tells us. This boils down to clinical experience, judgment, and having that conversation with the patient. And then, of course, there's the issue of trying to reduce harm and waste. One of my medical oncology colleagues, where I used to work in Ninewells, drew my attention to these survival curves in patients who have metastatic non-small cell lung cancer. And the interesting thing is there's clearly a difference. And the difference is that the patients who get good palliative care do better than the patients who get radical oncological management. There is saving, and there's better outcomes for a patient. To try and pull all this together in the UK, we have the Academy of Medical Royal Colleges, 15 colleges, 5 faculties, and now they're trying to draw these disparate threads together to provide a uniform way forward for the Choosing Wisely programme in the UK. As surgeons, we have an organisation called the Surgical Forum, the 4 surgical colleges of the UK and Ireland, and the Federation of Surgical Specialty Associations. They came to the view when we met that we don't need to come up with a list of 5 procedures that we shouldn't do. They feel it's perhaps more important that we set a threshold for a given procedure. For example, when do you do a hemorrhoidectomy? Should everybody who comes to see you with a hernia have an operation, or should it be left alone? We're very keen on promoting patient choice, and for the reasons I've perhaps just outlined, maybe to try and step back from the over-reliance on evidence-based medicine. But one of the themes that did emerge was the need to standardise care in the UK, and I'll just touch on 2 of these. We have an NHS Atlas of Variation, and we've also undertaken a National Emergency Laparotomy Audit. If I just say a few things about the Atlas of Variation, 211 clinical commissioning groups in the UK, in England rather, that define how care is delivered. And look at the range in mortality per 100,000 for patients who are under 75 years of age who've got a cancer. So clearly there's going to be lots of variables here, but it does beg the question of whether the level of care and style of care delivery that you get under one commissioning group is the same as under others. And then we've got the National Emergency Laparotomy Audit. Now, if you look at this pie diagram, for any procedure or anything to have actually got 100% requirement of the standard, the coloured bars should go out right to the edge. Clearly, that's not the case across the majority of patients who require emergency laparotomy. For example, input from a consultant before they have an operation. Plenty of room for us to work there. So finally, let's go back into the international community again. I think we can see what we need to do in the UK. And one of the things that strikes me, that what's appropriate, choosing wisely for the UK, for Canada, for the USA, is not necessarily what's appropriate in other countries. Japan has been a fairly early adopter, but look at the sorts of recommendations that they're making. These are the sorts of recommendations, particularly if you take the top 4, that we would probably never in the UK consider applying anyway. So I do think this has to be put in the context of the nation that is trying to make these choices. And one of the interesting things that the Japanese teams have come up with is the problem they have is that their healthcare system is basically fee-for-service reimbursement. So if that is the case, what is the incentive for you to do less when you're going to get paid for doing more? A situation that probably can't continue. And then, of course, again, they highlight the issue with demanding patients. So what do I think, finally, about choosing wisely? Well, I think it's a good idea. What do patients think? Well, this is something I've just picked up 2 days ago from Wendy Leveson. Awareness of the Choosing Wisely campaign is fairly limited at the moment, but clearly patients who are engaged feel that some of the care that they get offered is not necessary and not relevant, and that they would like more help for their support in decision making. And where it has been applied, there does appear to be a cost saving for surgical patients and indeed for all patients across the medical floors. So I would say, in conclusion, that choosing wisely is not just about making lists. It's a lot more about taking time to reach a shared decision with a patient. And I think it's a timely reminder for us that we are not simply technicians. And I think all of us will be working sooner or later in a healthcare system with a finite resource, and one doctor's waste is another patient's delay. So I think that's my summation of the role of it all. Choosing wisely, not only medicine. Here's another example of choosing wisely. The UK has exited the European Union. We may well come to rue the day that we have done that. And looking forward, I think there's an even greater risk when it comes to choosing wisely. And I'm sure, I'm absolutely sure that a wise decision will be made, Hilary, in due course. What a handy name to have, eh? I think that's all that I wish to say. Thank you, and thank you for the opportunity.
Thank you very much, Mr. Lavelle-Jones. Thank you for the thoughtful delivery of the lecture. So it's actually something we have to really think about because of the aging population and the limited resources. We asked Professor Stephen Chang to present the souvenir to